Here. Good afternoon, everyone. We are going to start another session of Nepal Ophthalmic Society from Nepal. Nepal Ophthalmic Society is very grateful and thankful to AIOS providing this special session as an international symposium. And we are here 6 speakers and talking about different type of talks. So this is a kind of the mixed topics here. And myself, Dr. Rohit Saiju, I'm the president of Nepal Ophthalmic Society, and my colleague, Dr. Lily Rajbansi, she's from Viratnagar Eye Hospital. Just in the brief, I would welcome all of you here, and I guess our other colleagues are on the way to join this session. Here we have doctors whom briefly we will introduce actually. The first speaker is Dr. Lily Rajbansi. She is a vitreoretina specialist. She completed her MD Ophthalmology residency and vitreoretina surgery long-term fellowship from Tilganga Institute of Ophthalmology in Kathmandu. And as a consultant vitreoretina surgeon, she is working in Viratnagar Eye Hospital. In Viratnagar, that is a southwest part of the country. And she is assistant professor of National Academy for Medical Science, Nepal. And Dr. Lily will present her experience with the ocular cysticercosis. She will be presenting a video, and I would like to ask all the speakers to stick with the time.
A very good afternoon. I'm very privileged to present here and share my experience of a case of intraocular and orbital cysticercosis. 45 years male from Bihar came on our OPD on 27th 2011 of 2020 with a complaint of gradual painless blurring of vision in his right eye, and it was for 6 months. There was no history of trauma, and there was no other ocular and systemic illnesses. On presentation, his visual acuity in right eye was 6/36, which did not improve on retinoscopy or pinhole, and in left eye it was a normal vision. Intraocular pressure was normal in both the eyes, and pupils were normal size and well reacting. There was no RAPD. On presentation of the right eye, we can see a mild congestion and pingicula on the conjunctiva. Otherwise, it was normal. On fundus examination, we can see there is a moderate amount of vitritis along with some tints of hemorrhages there. And on the superotemporal part, we can see a well-defined cystic lesion of grayish-white color, which gave a suspicion of cystic, like we are almost confirmed that it was a case of cysticercosis. Whereas the left eye was anterior segment was also normal, and fundus was also normal of the left eye. There was no vitritis in that eye. So we, since we suspected cysticercosis, we sent the patient for B scan, where we can see the cystic lesion with hypoechoic surrounding, and the central there is a hyperechoic lesion which suggested of scolex, and there was same type of lesion was also seen in the medial rectus. So there was cysticercosis in the vitreous cavity as well as in the rectus also. So we sent for the lab investigation. There was mild eosinophilia and raised ESR. Otherwise, other parameters were normal. And after a few days, we had done another blood investigation, where we found there was a marked raised in the eosinophils, but here I could not get that report. So sorry for that, but there was a marked rise in the eosinophils in the other report also. We started the treatment immediately with prednisolone. The weight of the patient was 60 kilograms, so we started with 60 milligram, was tapered weekly, and from starting from the 60 mg, we ended with 10 mg OD, and along with that. He was advised to take albendazole 400 milligram BD for 4 weeks, and also pantoprazole 40 milligram OD for 4 weeks. And we also advise him to go for neurology consultation to rule out any cysticercosis in the brain, and also advised CT scan head and orbit. And we planned pars plana vitrectomy for the right eye. He came with the CT scan report after a few weeks, and there was cystic cysticercosis on the brain also, along with the rectus muscle of the both the eyes. And then he again as we had advised pars plana vitrectomy, he was not ready for that, and he lost to follow up. And but when his vision was started deteriorating, then he again came after a few weeks, and that time his vision was 666 in that right eye, and it was normal in the left eye. So we can see the vitritis has increased, and that obscuring the that cystic lesion was which was like clearly visible earlier, was now a little faint to visualize. So there is so that time he agreed for the surgery, and we went for the pars plana vitrectomy. Can we have the video, please? So we did his pars plana vitrectomy 23 gauge vitrectomy system. Here we can see the amount of vitritis there and the floating cyst. Uh, so it was my first case of doing vitrectomy in the cysticercosis cases, and um, I tried to remove it in toto, and I had had seen many videos before doing that vitrectomy, and I my goal was to remove it in toto. So I was trying hard for that, after clearing the vitreous from center and periphery, uh, it was some attachments in the periphery, uh, but there was no tear. And because the cyst was large, I make a sclerotomy and wanted to try to remove it, but it was a large in size, and it was not coming. So eventually I only could remove the capsule, and central part fell down, and I removed it by cutter. So I could have made that sclerotomy larger, but I did not do that because it could um, bring more complications by doing more larger sclerotomy. So I cut it with a cutter. So there is so it was closed. The sclerotomy site was closed by 60 Vicryl, and then other ports were closed with 80. and specimen was sent for histopathology uh, call report, and that also suggested of cysticercosis. And patient was called on after 2 weeks, and that time enter segment was clear lens was clear, there was no cells and reactions, and there was mild congestion though, and intraocular pressure was also normal. And the main thing is visual acuity was 6.9 on that eye, and patient was very happy, and fundus was also clear. uh, Thank you. So patient was quite doing well. That after that, I could not trace him for the further evaluation, but I hope he is doing well. That's why he lost to follow up. Thank you very much. This is our beautiful hospital in Biratnagar, called Biratnagar Eye Hospital. Thank you for your kind.
Thank you, Dr. Lily, for a beautiful
Thank-
case and successful outcome. Congratulations.
Thank you, sir.
Now, next talk will be myself, and I'll be talking on eyelid rehabilitation in thyroid eye disease.
Thank you, sir. Our next speaker, our sir, is president of current Nepal Ophthalmic Society, and he's also dearest and respected my teacher, and he's professor in Tilganga Institute of Ophthalmology for 2 decades now, and he's a head of oculoplastic department also.
Thank you for a nice introduction. Good afternoon once again, everyone. I would like once again thanks to AIOS, especially Dr. Namrata Sharma, with whom we were in communication for a long time. And this session was, the kind of the suspicious whether to be or not. But in the last moment, we submitted our session, and they, with respect, they accept our the session, and so we are here now. My talk is eyelid rehabilitation in thyroid eye disease. I do not have any financial interest to disclose, and all the photos and videos are consented to produce here. We'll be discuss about management and surgical rehabilitation, not in the evaluation and introduction anyway, but still, what is thyroid eye disease? You know that in the population, there are many thyroid cases are increasing, maybe due to they diagnose properly nowadays, and hypothyroidism is the most common, and then proceed by hypothyroidism and euthyroid, but thyroid eye disease can occur in any kind of thyroidism. And surprisingly, in this part of the Indian subcontinent, the thyroid eye disease is not so severe as we are seeing in the Western Hemisphere. And once the active stage has gone, thyroid eye disease convert to the passive stage or burned out stage, where the different disfiguring changes will occur in periocular region, so that they come to us for the restorative surgery to be performed by ophthalmologists or oculoplastic units. The treatment option we had is non-surgical and surgical. And non-surgical technique, there is a magical drug named Teplotimab, which was approved in January 2020 by FDA, and this is one of the very fantastic drug available in the Western countries, but still the availability and affordability in countries like Nepal and India is still questionable. This is a monoclonal therapy which inhibits insulin-like growth factor in the orbital fibroblasts and adipocytes, which are the responsible exactly for thyroid eye disease in the orbit. The response is so quick that in the first and second and third dose, they start to respond, and usually the long lasting action, and there's very less chance of recurrence with this drug. And the delivery method is that every 3 weeks the infusion is given in 8 cycles, altogether 24 weeks, and the second dose and third dose in 6 and 9 weeks they start to regress, not only stop the progress. This is the fantastic effect that it start to regress the pathogenesis of thyroid eye disease. And the cost is very high if you are not insured. Even in the Western country, the affordability is very difficult. This is the slide I borrowed from my colleague Raman Class. He is the expert in thyroid eye disease, working in Los Angeles. And the right hand side, you see the patient in the left eye. There is a remarkable lid retraction and proptosis. After the one dose of Tepeza, that is a trade name for the Teplotimab, after 3-4 weeks after first infusion, start to regress the exophthalmos as well as the lid retraction. After completion of the doses in 24 weeks, almost completely resolved the lid retraction and exophthalmos in the left eye. In the left hand side, you see her patient before and after the administration of the Teplotimab. These are my patient in the burnout stage of thyroid eye disease, where you can see remarkable exophthalmos, severe lid retraction, and different direction deviated strabismus. So which make they are socially handicapped, and as well as the disfiguration make their very much difficult to live in the normal style. In the upper eyelid retraction, there are two methods to resist the retractor of superior palpebral, levator palpebral superior and mular muscle, or full thickness graded blepharotomy. These are the choice for the upper eyelid retraction recession procedure. In the graded blepharotomy technique, which was described first by Leo Korniev in 1990s from Netherlands, what he does that in the lid crease approach, give the incision suborbicularis incision, then go to the levator recession, leaving the stump of the conjunctiva in the central to maintain the contour of the upper eyelid. And this is very promising and is graded. If the severely retracted lid, it can be completely they do the blepharotomy. If it is mild, then you can judge in the table how the results are coming. Blepharotomy can be combined with the blepharoplasty. You know that in thyroid eye disease, there is a puffy eyelids due to the subbrow fat pads infiltration, as well as excess lid, which can be removed during the blepharotomy surgery. Now come to the lower eyelid retraction. Lower eyelid retraction is responsible by lower eyelid retractor muscle capsule palpebral fascia, where you see here, this is the tarsus, and just beneath the tarsus, there is a spacer has placed between the inferior border of the tarsus and inferior retractor capsule palpebral fascia, which elevate the lid toward the limbus. So this is one of my patient whom the burnt out thyroid eye disease, burnt out thyroidism with the thyroid eye disease. There's a remarkable lid retraction and exophthalmos after the lid everted with the traction suture with Demar retractor, conjunctival anesthesia with infiltration given, and they're leaving the 4 millimeter of tarsus from the eyelashes, then given the incision in the tarsus, and subtarsal dissection is carrying out here very nicely. You see that it is very easy to dissect the subtarsal because of there is a very loose adhesion between the tissue. And now the tarsus and conjunctival graft has been harvested very nicely, and we keep in the saline for the time. So 1 millimeter of lid retraction can be corrected with 2 millimeter of spacer. Here he has got about 3 millimeter of lid retraction. That's why about 6 millimeter of spacer is needed in my case. Now come to the eyelid recession procedure. After giving the lid crease incision, then capsular palpebral fascial incision, you reach to the conjunctiva and mular tissue, where you extend your incision toward the medial extremely, and in the same way you extend your incision toward the lateral side of the eyelid, and to be ensure that the lateral horn of the levator palpebral superior should be in size, because this is the muscle part which is responsible for lateral flaring, lifting the eyelid laterally up and leaving the central hinge of conjunctiva to maintain the contour of the upper eyelid, and then close the eyelid into 2 layers. Because I start to close in 2 layers, I had some of the cases having the wound gap, and once wound gap is there, cornea is directly visible like it's a buttonhole. That's why you nicely close orbicularis in one layer and skin in another layer. Now come to the lower eyelid retraction correction. Giving the traction suture here before Vicryl. Do I have 2 minutes only? Yeah. Oh, so quick. Uh, and you see the anatomical landmark of inferior border of the tarsus and giving the incision in the inferior border of the tarsus here. And now you do the subconjunctival dissection nicely and identify the inferior retractor muscle capsuloparietal fascia. And I recall that we have harvested very nicely the tarsoconjunctival graft from the upper eyelid from the same patient. The spacer could be the different material. We can use, this is the capsuloparietal fascia. You see the whitish band, and the graft is now placing properly as a spacer between two structures, inferior border of the tarsus and superior border of the capsuloparietal fascia. And we suture that with 6 of Vicryl very nicely here. And the spacer could be nasal cartilage, ear cartilage, or donor sclera, or hard palate, or tarsus from the upper eyelid, autologous tarsus. It is sutured and placed very nicely in the fornix, you see, and release the traction suture. Keep the frost suture for 3 days just to keep in the position. And you'll see that, yeah, it is very nicely placed in the inferior fornix and keep for this. And this is the post-operative 1 week picture where the lid retraction has remarkably reduced, and we didn't do anything from the exophthalmos. Now come to some of the successful stories. This is my very first case is in 2005 done for the burned out case of thyroid eye disease, and where I had a hard palate graft for the lady and post-operatively found the satisfactory result in the same way. In 2010, right eye lid retraction was corrected. After 8 years, the same thing happened in the left eye and came from US to get the treatment with us. And here you go, another cases, and where I combined with the blepharoplasty with the fat reduction, and after successful surgery, you see the inferior retractor is still be there. And in summary, I would like to summarize that the rejuvenation or restoration of the appearance, normal appearance of the patient is very important to restore his or her normal life in the society, and which can be done with customized approach for the individual patient. Thank you very much. Thank you.
Thank you, sir. It was a really nice presentation with very important topic, and there were such beautiful videos, and it made me recall my residency days where I used to assist you on such cases, and it was very nice. Our next presenter is Dr. Ratna Singh Rana. She is cornea consultant in the Tilganga Institute of Ophthalmology and is also an assistant professor in National Academy of Medical Sciences.
Thank you, Lily. So very good afternoon to you all. As Lily has mentioned, so I'm doing in my cornea practice in Tilganga Institute of Ophthalmology as a faculty. So we know that with the advance of our Nepal Eye Bank, which was established in 1996, that it had made us, our corneal surgeons, for the different types of keratoplasty. So we know that the different types of keratoplasty includes anterolamellar and posterolamellar. Not only that, we have a patch graft also. In the cases where we have ocular trauma, ocular infections, where we saw the patients in the emergency, and we thought of, okay, what we are going to do, because we are treating the infections. But at the meantime, we have, sometimes it's, while we are treating for the infections, again, the chance of having perforation and chance of having losing of the eye is also there. So I think the corneal patch graft and corneoscleral patch graft has given the advantages in those cases. So I am going to take present on some multifacets of corneal patch graft in different corneal conditions that which I saw in my hospital in Tilganga Institute of Ophthalmology. So cornea patch graft has been advocated as the surgical procedure to treat a variety of anterior segment pathologies. It involves patching the affected area with full thickness or partial thickness corneal donor tissue. The aim is to restore the globe integrity and it prevent further inflammation that could lead to the devastating complications such as endophthalmitis. So cornea perforation and melting can occur in infectious keratitis, autoimmune diseases such as rheumatoid arthritis, ocular trauma, and ocular surface disorder. So cornea patch graft has been indicated in cases of corneal perforation, cornea thinning, scleral thinning, or as prophylaxis to prevent the exposure of glaucoma device and drainage devices. So the advantage, which is compared to the others in cornea patch graft, is it is translucent, less chance of graft melting, and conjunctival retraction. So it can provide good tectonic support for the ocular wall as the tissue has good strength and the rigidity. So the case series of the corneal disease which has been treated in our hospital is listed here. So regarding the some cases which I have presented, which I am going to present here. So case 1, a 30-year-old lady presented with swelling in the left eye since birth. According to the patient, it was increasing in size and blurring of vision since 1 year. So her vision was 618 with the refraction +4 spherical and MENS 2.5 in 180 degree gives her to 612 vision. She was diagnosed with right eye limbal dermoid. So this picture 1 shows it's a right eye limbal dermoid, which is temporal inferior nasal limbal dermoid. So in the second picture, you can see that right eye dermoid excision has been done. So not in all cases we do the patch graft, but it can be again divided into the superficial and the deep. So deep limbal dermoid, which we think that while doing the excision, there might be a cornea thinning and perforation. The risk of perforation is there. So we plan for dermoid excision and corneal patch graft at the same time. So we did the corneal patch graft at that time. In the picture B, you can see that very nicely the corneal patch graft had been sutured in the place. So the third picture that we have sent for the histopathological examination. So here you can see that the post-operatively the graft looked stable, and the histopathology report also shows that it is a limbal dermoid. So in case 2, a 55-year-old lady presented with pain and redness for 2 months. On examination, there was peripheral ulceration from 7 to 1 o'clock. She was diagnosed as left eye Murran ulcer. So with all the history and clinical examination, she was referred to rheumatologist and diagnosed as having rheumatoid arthritis. So she was treated on corticosteroids and antibiotics and immunosuppressive drugs. So after some days with the treatment of all these medications, then she had undergone the corneal patch graft. Here you can see that in number 1 there's a case of Murran ulcer. In figure B, you can see that the banana-shaped patch graft has been placed, and it is very nicely, you can see AC was formed, and it was very nicely placed. In case 3, a 27-year-old gentleman presented with left eye impending perforation with eyes plug at 6 o'clock position. AC was formed but no leakage. So he has, when asking for the history, he gives a history of trauma in childhood and decreased vision since then. So his pre-op vision was 618. So he had undergone a corneal patch graft with thinking of it might perforate. So in the second picture, you can see that there's a post-op corneal patch graft. His post-op vision was 618 again, and AC was formed. A 35-year-old male from Gokarna presented with history of injury with paddy leaf, a week back on right eye. The vision was 6/5/36 at that time. He had dysmatocele in inferior cornea affecting from 5 to 7 o'clock with iris prolapse and sallow AC, but no leakage on presentation. Pseudocornea was formed. The eyeball was soft. So he had undergone a corneal patch graft under local anesthesia. His post-operative vision was plus 1.5 in 90 degrees 6/9, and AC was formed. This is a 5th case. So a 40-year-old lady had history of trauma with turn 1 day back. But see, when asking, she had a history of similar trauma on the same eye for which she had done corneal repair twice. She presented with right eye perforation at the site of ciliary staphylomas, and CDL test was positive. Her vision was NPL on that eye, but the sake of to preserve his integrity of the globe, we planned for sclerocorneal patch graft for the tectonic purpose. And you can see that in A and B, both the pictures, you can see that the cornea and the sclera has been used for the patch graft. AC was formed after surgery. So regarding discussion, cornea melting is a sequelae of progressive keratolytic process. Untreated cases can lead to the cornea perforation. Application of corneal patch graft is an emerging technique to address this complication. Patch graft can be full thickness or partial thickness. So when the cornea defect is too large for the application of the cyanoacrylate tissue or the application failure, corneal patch graft can be used. These techniques will allow the preservation of the globe integrity and stabilize the eye. In this case series, the cornea patch graft was planned as the patient were not responding to the medical treatment. In case 1, cornea patch graft was used in post-limbal dermoid excision, which gives the stability of the globe. In case 2, it involves use of the corneal patch graft in Murren's ulcer. In Murren's ulcer, stepwise treatment with corticosteroids and initiation of the immunosuppressive agents after consultation with rheumatologist is commenced. Conjunctival resection is also done to remove the presence of complements, immunoglobulins and inflammatory cells. Even after all the measures, if the peripheral thinning and melting is more severe, then the cornea patch graft is applied to prevent from the perforation. In case 3 and 4, it involves the patch graft in corneal thinning, in dysmatocele and impending perforation due to trauma and infections. Pseudocornea was formed to prevent from the dreadful complications like endophthalmitis. After the perforation, tectonic corneal patch graft was planned. As the thinning and perforation were in the periphery, visual potential was very good in both the cases. So a tectonic patch graft is a useful therapeutic option in selected cases of corneal thinning and perforation, in which they are not only restore the ocular integrity, but prevent progressive pathologic changes and help in optimal visual function. So all patients who underwent this patch graft surgery were treated with topical corticosteroids and topical antibiotics. Lubricants were also used. Oral corticosteroids and immunosuppressive agents were given before the surgery after consultation with the rheumatologist in cases of Murren's ulcer. So in conclusion, corneal patch graft has evidence to improve the outcome in treating the anterior segment disorder, especially involving the cornea and sclera. Its advantages have made it possible to produce a good post-operative result, functionally or cosmetically. There's a lot of published literature which shows that corneal patch graft is an adaptable technique that can be used with a variety of vision-threatening disease. Having said that, I thought that because I'm privileged to do this surgery, because I worked in an institute where there is an eye bank nearby my hospital where I can get anytime the cornea, the donor cornea. So I like to say to my other colleagues that the cornea, the donor cornea, we have to counsel about we have to counsel about the cornea donation to our places where we worked for. So I think from the eye bank, they are doing a very excellent job in providing a cornea, donor cornea to us. So thank you so much. This is my hospital where I'm working. This is Tilganga Institute of Ophthalmology. I'm very highly obliged to my hospital and this Nepal Ophthalmic Society, especially Dr. Saiju, for giving me this grand opportunity to present over here. Thank you so much.
Thank you, Dr. Rachna, for a very nice presentation and very beautiful series of cases with excellent outcome. And being my batchmate, I'm very proud of you. Thank you.
Can the technical team little bit extend the time, because each speaker has given 13 minutes instead of 10 minutes. Please elongate 3 minutes. Thank you very much. Now the next speaker is Dr. Roshija Kanal. She is a consultant vitreoretina surgeon from ASC Hospital, Kathmandu, and she had to work in the high volume surgery hospital in LEI for a long time, and she is a very experienced vitreoretina surgeon, under whom few vitreoretina surgeons are produced in the country. So I would welcome Dr. Roshija, please. Over to you.
Okay. Thank you, sir. Good afternoon, everybody. AI in ophthalmology. This topic is relatively very new for me, and I thought this would be perfect chance for me to understand what AI is. But after a few days of research, I came to know that this is really very vast and can only be explained better by a scientist or a mathematician. So I'm just going to share a brief about what I've just understood about AI in ophthalmology. Though it might be vast, but we've been revolutionized by AI in our day to day life, including voice command that we use very frequently, like Siri, Alexa, Cortana. That's a very day to day activity for us these days. So, next, face recognition. We open our apps, office, and accounts and everything with this software. Next is natural language processing, where the computers really understand what you're talking, be it any language, any tone, or any country or region that you belong to. This is also one very amazing AI development, I believe. So next is autonomous vehicle, and we can see that the vehicle in the center, the radar is like really sensing all the obstacles and the pedestrian, what distance they are located in, and just goes on self-driving, and even unmanned plane now. So when the vehicles and planes have been like placed by AI, can doctors be replaced by AI as well? So we need to see. So what is AI? AI is the simulation of human intelligence processes by machine, especially computer systems. The concept and existence of AI is not new though. Even when there was no internet in the past, I believe that people would have been researching about AI, reading newspapers. And I believe people wanted to know if they could teach computers to learn how a young child would learn. The concept, I believe, was to basically use trial and error to develop formal reasoning. The term AI was coined way back in 1956 by John McCarthy. In my opinion, AI is the simulation of human intelligence but done by machine programmed by us. The machine, however, need to learn how to reason and do some self-correction as needed along the way. AI works by combining large sets of data with intelligent, iterative processing algorithms to learn from patterns and features in the data that they analyze. And each time an AI system runs around the data processing, it tests and measures its own performance and develops additional expertise. And I think that's an amazing feature. So the basics of AI include machine learning, deep learning, and neural networks. There is this term called simple automated detectors. It is a system that is fed an algorithm that identifies the presence or absence of features. Like we say, what is BRVO? We feed the data that the presence of flame-shaped hemorrhage and cotton spots in a quadrant would be MAC BRVO, and the computer would recognize if an image is given that way. Next is machine learning. AI is constructed on a set of algorithms that they try to imitate human intelligence. Machine learning is one of these algorithms, and deep learning is a sub-skill of a machine learning technique. It consumes data and uses statistics to better learn the data, in turn improving the ability to solve the task. It is made of both supervised and unsupervised learning. Supervised learning learns on a labeled data set, allowing you to produce outputs based on previous data. In contrast, unsupervised learning uses unlabeled data to learn on and discover unknown patterns in data. Next is deep learning. It is also known as deep neural learning. It is a type of machine learning technique that tries to imitate the human brain by imputing data through a biological inspired neural network that contains a number of hidden layers. So truly, it really has a lot of neurons, just like human brain does. It helps in transmitting the signals by a lot of hidden layers, and then they give the output. So through the hidden data, the data is processed, making connections and creating patterns. And it has revolutionized the world of AI. Again, I said, like Google Assistant, face recognition, natural language processing, and everything comes under the AI, deep learning subset of AI. What are the pros of having AI? I think it helps in reducing the human error, task risks instead of human, available 24/7, helping in repetitive jobs, digital assistance, faster decisions, daily applications, and new inventions. The cons being that there's a high cost of creation of these softwares. Are these making humans lazy, unemployment, no emotion, and lacking out-of-the-box thinking? So why do we need AI in healthcare ophthalmology? Because I believe that experts cannot be everywhere for everybody. The number of diseases and the number of healthcare providers, it is just out of the ratio. And people really, they have a lot of morbidity and a lot of preventable diseases and blindness. And for screening and referral, I think AI would just be perfect. The imaging modalities in AI that we can implement is, sorry, can I have the picture? Sorry for interruption. So we have fundus image, optical coherence tomography, ocular ultrasound B scan, slit lamp image, visual field biometry. So now we come how AI helps in certain diseases. And I think AI in ophthalmology, the first FDA approved AI was IDXDR for diabetic retinopathy screening. So let me just brief a little about it. Diabetes, we know that it affects a lot of people worldwide, and automated techniques for DR diagnosis have been explored to improve the management of patients with DR and alleviate social burden. It was used to predict DR risk and DR progression among diabetic patients to combat with this worldwide disease. So there are two images. First is the fundus image, and how the other one is cloud-based software like IDXDR identifying these features. So we can see that here there is a little bit of hemorrhage that is picked up as the signal, and the lesions here are picked up as signals. And I think the computer really understands what needs to be referred and what does not need to be referred. So there are a lot of studies after IDXDR, and they are showing a lot of great reports regarding sensitivity and specificity of disease screening, diagnosis, and referral. So IDXDR, like I said, was the first FDA-approved software package for DR screening in non-ophthalmic healthcare practice. It is a cloud-based software with a built-in retinal camera implemented in American institutions. It evaluates image quality and detects retinal findings related to DR, providing classification regarding the referral disease. It reports a sensitivity of 96.8 for referral DR and a specificity of 59.4. I think that's a good number. So there are a lot of other softwares as well in different countries, like RedMarker is there in Portugal, and it is having a sensitivity of 95% for referable DR and specificity of 63.2. And there is iArt, and it is also having good sensitivity and specificity as well. Next is iGrading M. So we can see that these softwares are really helping us achieve very better diagnosis, and I believe the rate of this sensitivity and specificity will only go higher and higher in the future. So next disease that AI has been used in is ARMD. It is still under trial, and I don't think there is any commercial software that is really FDA approved for ARMD as yet. So in ARMD, AI uses OCT images, and it can be trained to perform segmentation, classification, and prediction. In segmentation, many AI systems were shown to display highly accuracy in segmenting different retinal layers on OCT. And this is important to quantify intraretinal fluid, subretinal fluid, and pigment epithelial detachment. And volumetric analysis of intraretinal fluid and region have also been evaluated using deep learning methods. So these systems really tell you, like, can it be absorbed and should they be given anti-VEGFs? So that also helps in very good referral and just prevent in blindness again. Preliminary studies have shown that the use of fundus images as input original materials and extract features of early, intermediate, and late AMD to distinguish from healthy images. They can obtain a sensitivity ranging from 87 to 100%, also with a relatively high accuracy. They think taking fundus photo as input is cheaper than OCT examination. So these are few studies having different specificity and sensitivity, but it is again good number, and I believe would only go higher and higher in coming days again. So next is ROP. So this is one emerging disease that we really have problem diagnosing, very less referral, and a lot of preventable blindness again. So there is challenges in retinopathy of prematurity screening and diagnosis, including diagnostic variability, paucity of specialists in ROP, and access to care issues. Machine learning systems have been developed as a possible solution to address these challenges. The systems evaluate vascular changes, features of the disease such as zone or stage, and category of disease and disease progression. So you can see that we really we don't need anybody to really go and see fundus when these AI can really help detect all this demarcation line or ridge there, or there is fibrovascular prolif, there is a detachment, total detachment, dilatation of tortuosity of retinal vessels. So these are very well detected by AI. So glaucoma is again one preventable disease, and a lot of people are coming to healthcare providers only at the end stage. So diagnosing this in early stage again would help a lot in preventing blindness again. So Els et al. Developed an unsupervised computer program to analyze visual field that recognizes clinically relevant and visual field loss patterns and assigns a weighting coefficient for each of them. This method has proven useful in detection of early visual field loss from glaucoma. So all these images, what they help in doing is creating data. A lot of data, better data is only going to make strong algorithms and help better softwares detect the disease and help what needs to be referred, what needs to be observed, who should go to the doctor, and so take care of everything in the future. But this again has a lot of issues as ethical issues as well, and it is still under study and concern how these medical legal aspects can be handled in the future. So other diseases apart from what I just spoke on is AI is still working on diseases like retinal vein occlusions, cataract, keratoconus, corneal ectasia, myopia progression, and oculoplastic reconstruction. And I think AI is really going to be an integral part of ophthalmology very soon, and we need to be acquainted to it as well. Yeah, thank you once again for having me.
Yes, AI is today's and tomorrow's perspective on ophthalmology as well. We'll entertain all the questions and remarks at the end of the session. We have about 10 to 15 minutes time for that. Now, next speaker, I would like to invite Dr. Anari Keshi. Dr. Anari is consultant vitreoretina surgeon from the Virat Eye Hospital located in the Virat Nagar, southwest part of the country. And he has been working as a consultant VR surgeon for this hospital about 5 years, I guess, for 5 years, and doing very well in the region. He will be sharing his experience in diabetic retinopathy. Dr. Anadi, please.
Good afternoon, everyone, and thank you, sir, for your kind introduction. And today my topic is on diabetic retinopathy, and more than my experience, I think I'll be discussing on why we need to think this entirety differently. So I have nothing to disclose. And we all know that diabetic retinopathy is among the fastest emerging epidemic globally and affects the macro and the microvascular components of the different target organs, and one of them being the eye. So we already know, I'm not going to discuss much about this. We all know the baseline characteristics, the risk factors, the stagings, the comorbidities, complications, and the treatment. And we also know the treatment outcomes of different agents, such as anti-VEGFs, steroids, lasers that are used. And even despite the treatment, if the patient is not following the discipline properly, we know how the outcomes are. And I think COVID-19 has taught us a very valuable lesson that, if what happens to a diabetic patient if they are lost to follow-up, or if we rely too much on anti-VEGFs than the lasers. So even after so much understanding, the outcomes of all the diabetic retinopathy patients are very, very variable. So we have to question ourselves that do we have to create better monitoring parameters? Because if the treatment is if we approach it in a blanket way, or if it's so well established, then why are there so much variations in the clinical outcomes? And again, there's a differing results. Then if not, then what more? Are we in the previous presentation we talk about artificial intelligence and the AI. So are we relying too much on the machines? Because the AI should be not an artificial intelligence, but we being humans, it should be actual intelligence, not an artificial intelligence. So are we being too dependent on imaging or investigations? So these are the places where we lead. So screening, diagnosis, staging, and we have become so good at confirming, reconfirming, reconfirming, and again, doing it over and over again. And we, of course, know the treatments. So, and we do have the standards set by the ICO and PPE, PPP, the preferred practice pattern by the AO regarding the follow-ups. But then, if we look inside, there still seems to be a missing factor. And again, as I said, have we become too dependent on the technology? And recently, there's a term coined vomit, which means the victims of modern imaging technology. So are we, putting our patients into a vomit category, and are we still following the fundamentals as we are becoming more and more dependent on the technology? So basically, to the very basics, I'd just like to ask the audience, how many of you send for HbA1c? I think everyone does that. But then how many send for hemoglobin? Very few, or almost none. Then, is it necessary or not? Because it's very, very important that you should understand that if the hemoglobin is not correct, or if the patient is anemic, then the patient is already at 2 times risk for retinopathy and 5 times increased risk for pre-proliferative or proliferative retinopathy. So, this is what the research has already shown, and I think that's the fundamentals, because the HbA1c is dependent on the HB, and there is already established data which says that up to 0.2 to 0.4 gram percent of HbA1c can be affected by a decrease of 1 gram of hemoglobin, and lower hemoglobin have a higher HbA1c at the same fasting glucose levels, consistent even across the non-diabetic range of fasting glucose, plasma glucose, meaning that if we are taking HbA1c in a patient who is anemic, we might be falsely labeling that as diabetic patients if we don't check the hemoglobin. So, with this, we performed a small study, and we correlated the hemoglobin levels and glycated hemoglobins with the severity of diabetic retinopathy. And again, this is our work recently we've been doing. So we are introducing DIARY, which means the Diabetic Retinopathy Risk Index, with an introduction of the HB to HbA1c ratios, and which we think could be a noble indicator for predicting the severity of diabetic retinopathy. So this is our methodology. We take the patients, we take the fundus pictures, then we grade them. We check the the hemoglobin and the HbA1c levels. Then patients who have received previous treatment or with patients with renal impairment and anemia are excluded from the study. So altogether, we evaluated 224 patients, and 66%, almost 2/3 of them were male. And the mean hemoglobin was 12.7 and the HbA1c 8.76. So, if we look into the data, then we found that comparing throughout the different stages of the diabetic retinopathy, hemoglobin levels were fluctuating. So if you can see, it does not have a very linear relationship, and actually where you would just predict the hemoglobin to even drop further, than they were having higher hemoglobins. This is probably, the patients, when they reach, by the time they reach the very severe NPDR, their physicians might be over-treating them or treating them more aggressive. So they might be correcting in the terms of hemoglobin levels, and similarly HbA1c levels as well. It does have some linearity, but not a very practical or a very easily interpretable linear relationship. So as I just mentioned, they're not really linear and very hard to predict. So with this, we introduced the DIARY scale. Again, it's the Diabetic Relative Risk Index. So over here, what we basically do is HB to HbA1c ratio. So these were the various ratios, and if you compare throughout the different classifications of the diabetic retinopathy, you can see that it does have a linear relationship. So for mild, it was 1.84, so HRPDR 1.21, somewhere in between, it's 1.62. So what does this really all mean? So this is a diary scale. So 1.84, we create a scale like this, and we have the mild, moderate, severe, and PDR. So how will it help? So let's put the system to a test. So a patient who is a clinically moderate NPDR with no CSME, then follow up as per the IC or the PPP, it's up to 6 months, or it can be extended to 9 months. But then you do HB to HbA1c ratio, then you find that the patient has 1.47. But if you look at the diary, and if it's a moderate, that patient should be having a 1.71. The range should be somewhere there, but it's observed is 1.47. So it means that the patient is somewhere between moderate and the severe, diabetic retinopathy grading. So what does this mean is that the patient is in the coming days is more likely to be pushed towards the severe than stay in the moderate or improve. So this means we have to rethink about the follow-up. Maybe even if we put this patient into a general category and say 6 or 9 months, maybe because of the observed diary value, this patient would require a follow-up earlier. So again, putting a second test. So there's a patient who has come with a PDR, then we do a PRP, anti-VEGFs, metabolic, and the endocrine workup. Then, the follow-up is variable in such cases because they are the PDR cases. But then, in this patient, the observed diary HB to HbA1c is 1.72. But again, if you look at the PDR, the expected value would be 1.21. But here, if you look into the values, then you think that the observed values are actually better than you were expected. So you would generally expect this patient to be doing better than the other patients. So this patient might have, a better sugar control, and maybe have a relatively lower risk of progressing into a PDR or HP. So you can really comment on a certain extent on the prognosis. Then this is another scenario where a patient might not be evaluated by an ophthalmologist, but only a physician. But then they do an HbA1c to HB. Then if you take this, the observed HbA1c alone is not alarming because it's somewhere around 1.7, 1.7. But then you observe the diary is 1.47. Actually, a first person, usually a patient with 7.5, we don't think it's an alarming thing. But then if you look at this diary, then it's 1.46. So it's somewhere around the moderate to very severe. So, we all get the point what this is trying to say. So we have been doing validation at our center and along with other 15 centers regarding if this is really, does it correlate well or not. So using Octa and OCT images, we have been getting very concrete data, but then, it will be over time, and we will need a lot of data to actually confirm and to actually validate all of these points. So to conclude, the diabetes is very well understood, but the management still, I think we all, just by looking at this, do think that the management may require revision. The HbA1c levels remain one of the most reliable predictors of glycemic control, but then, this finding further elaborates why hemoglobin should also be considered in managing the treatment of a patient with diabetes and diabetic retinopathy. So basically, back to the fundamentals, keep your basics very sharp because HB and HbA1c, they are interrelated. We have gone through over time by time and in our med schools and in biochemistry. So if hemoglobin levels are not to be considered along with the HbA1c, the desired target levels to slow down or halt the progression of the diabetic retinopathy may be better understood with using the diary. And diary could be one of the very first biomarker. It's not a very hi-fi or a very, a very high-tech thing. It's just using the basics to just realign yourself and treat the patients better. So noteworthy take-home message will be that the diary paves path to translate clinical findings into clinical guidelines, and we can also help in customizing the treatment because sometimes we do have to ask that why and how are our two patients, when they are falling into the same category and receiving the same treatment, have different risk of progression in the diabetic retinopathy. So with this being said, the guidelines for follow-up and management with integration of the diary should be thought of then applying a blanket approach based solely on staging of diabetic retinopathy. For that, of course, I would be looking forward to collaborate with multiple centers, national and internationally, to perform a large multi-center validation for diary. And this is, I, in long term, do believe that it would not just save the eye from the damage, but limit the damage from happening itself in the first place. With this being said, I would like to thank you for your kind attention. Thank you.
Thank you, Dr. Anadi, for very nice and important presentation. Now we are almost at the end of our session, and our last presenter is Dr. Rojita Parajudi. She is consultant pediatric ophthalmologist in Tiruganga Institute of Ophthalmology and also assistant professor of National Academy of Medical Sciences. She is going to present on outcome of horizontal establishment surgery and the influencing factors of the surgical success. Please, Dr. Rojita, please.
Thank you, Dr. Lily, for your kind information. Good afternoon. Namaste to everyone. Today I am presenting the outcome of horizontal establishment surgery and the influencing factor of surgical success. First of all, introduction. Strabismus is a common problem in ophthalmology, and its prevalence is 3 to 5% in the population. And it has attracted attention for several reasons. It is associated with all psychological difficulties that have a detrimental effect on patient quality of life, especially in children diagnosed with strabismus at the age of 5 years. There will be psychological changes. It is a challenge to achieve the desired results with a single surgical procedure. Strabismus is a complex problem of eye alignment, binocularity, and cosmetics, and it leads to establish the binocular fusion, eliminate. The surgery is mainly done to establish the binocular fusion, to eliminate the diplopia, expand the field of binocular vision, to correct the compensatory head posture, and to improve the cosmetic appearance. And to achieve all these goals, we need to have before surgery, we need to decide on type of strabismus and its surgery type, measurement of preoperative deviation, and the age at which the surgery was performed for the first time. Now, coming to the objectives of my study, the general objective is to evaluate the surgical outcome and the influencing factor for the surgical success of horizontal strabismus surgery. And the specific objectives are to find out the demographic profile of the patient undergoing the strabismus surgery, and to find out the type of horizontal strabismus in patient undergoing the surgery, and to find out the surgical outcome of strabismus surgery in terms of ocular alignment, restoration of binocular single vision, correction of strabismic amblyopia. Now moving towards the materials and method, the study was done in Tiruganga Institute of Ophthalmology. It was a retrospective hospital-based study which was conducted from June to December 2021, and data was taken from 2017 to 2020 from EMR. About 198 patients were included in the study in consecutive cases. The inclusion criteria were the patient who had undergone horizontal establishment surgery with the follow-up for at least 3 months, and the exclusion criteria was were paralytic squint, restrictive muscular disease, and repeat establishment surgery. The ethical approval was obtained from the Tiruganga Institute of Ophthalmology Research Ethics Committee. In methodology, after obtaining patients' medical history, detailed ophthalmological examination were performed. Visual acuity was measured by Snellen chart and Lear symbol. Extraocular muscle function were examined in 9 cardinal gauges position. Angle of deviation were evaluated by prism bar cover test at near and distance with and without glasses. For patients with poor vision and uncooperative patients, modified Krimsky tests were used to measure the angle of deviation. Titmus fly and Oort-4 dot test were used for evaluation of stereopsis, binocular vision, respectively. Glasses were prescribed according to refractive error and types of strabismus. Patching therapy was advised for amblyopic patients before surgery. The success of surgery was defined by eye deviation up to 10 prism diopter at 6 weeks after surgery. Guidelines in planning surgical amounts for esotropia and exotropia were measured on Marshall-Parks formula. The influencing factor for surgical success, such as age, diagnosis, visual acuity, binocular function, and angle of deviation, were also analyzed. For the categorical data, chi-square test, and for numerical data, independent t-test, Mann-Whitney U-test, where variable applicable were used. For surgical planning and surgical treatment, The surgery method was chosen according to the type of deviation, presence of amblyopia, and age of the patient. In children, an alternating screen bilateral surgery was performed. In older patients, monoocular surgery was performed. In small children and uncooperative patients, the surgery was performed in general anesthesia, and local anesthesia was chosen for younger patients. Surgery was done by an experienced surgeon. Fornix-based conjunctival incision was given, and horizontal muscles were grabbed. Recession and resection surgery was performed on the base of types of strabismus. 6-0 Vicryl suture was used for suturing the muscle to the sclera with double spatula needle, and 8-0 Vicryl suture was used to close the conjunctiva. Post-operative follow-up was done on first post-operative day, 1 week and 6 weeks and 3 months, and post-operative medication were given, and orthoptics evaluation was done on 6 weeks of follow-up. Now, coming towards the results, first of all, demographics of the patient. The median age was 17, and it was ranged from 6 to 53 years, and male is to female ratio is 0.96, and in age category, 59.6% were from 6 to 18 years old, 40.4% were from 18 to 53 years old. 51% were female, and 49% were male. In preoperative clinical parameters of the patient, out of 198 patients, 37.4% were exotropia, 62.6% were esotropia, 33.3% was right eye, 35.9% was left eye, and 30.8% was both eye. And in fusion and sterosis, it was at near it was present in 11.6% of the patient, and at distant it was only present in 4.5% of the patient. And preoperative angle of deviation, the mean was 48.9, and ST was 14.7, and the minimum was 10 prism diopter, and maximum was 90 prism diopter. In post-operative now coming to us, the post-operative deviation after surgery, there was a total success in 23.3% of the patient, that is total 45 patients. Among them, 31.9% were esotropic patient, and 18.2% were exotropic patient. Now, comparison of fusion and sterosis before surgery and 6 weeks after surgery. Before surgery, fusion was present only in 11.6% of the patient, which was increased to 38.3% of the patient after surgery at near. At distance, it was present in 4.5% of the patient, and it was increased to 20.7% of the patient. Accordingly, in sterosis was also increased in it was present only in 11.6% of the patient before surgery, which was increased to 35.2% of the patient. Now, coming to us, the analysis of influencing factor and the surgical success among the patient. We took mainly the variables like gender, diagnosis, binocular vision, amblyopia, preoperative angle of deviation, and age. Among them, only the preoperative angle of deviation came out to be significant, statistically significant, and all the other other variables, the p-value was not significant. That it shows that the preoperative angle of deviation was very important in strabismus surgery, and my study shows that if the preoperative deviation of the angle is less, the surgical success was very good. Now coming towards the discussion, the success rate of horizontal strabismus surgery in our study was 23.3%, and the failure was 76.7%. The failure was highest in exotropic patient. Similarly, 38.2% of the success was seen in a study done by Pandey, yes, et al. The success was 49% for esotropia and 26% for exotropia. In that study, 74% was failure in exotropia patient. Likely, Kamapest Skin Korn et al., Segal G et al., Ganguly S et al., Uzan A et al. Shows the success rate of ranging from 56.3% to 86.5%. Now, coming towards the limitation, it was a retrospective study, and I think the sample was also small in size. Now, to conclude, in horizontal concomitant strabismus, the preoperative amount of deviation is the most important factor for the surgical success. The surgical success is low in patient with large preoperative deviation patient, and the careful measurement of angle of deviation before surgery can increase the success rate. And the patient and their parents should be informed about the possibility of the residual deviation and need for another surgery in future. The binocular vision has also been improved in many patients, even though the p-value is not significant, but it can be taken as a good predictors of influencing factor for the surgical outcome in our study. Thank you so much.
Thank you, Rojita, for nice study. And conclusion, greater the preoperative deviation, success rate is less. Now, floor is open for discussion and question, remarks, etc. We have about 10 minutes of time. I have question to first presenter, my co-chair, Dr. Lily, that what we understood that intraocular cysticercosis is usually treated by surgical manipulation, and extraocular, where mostly the extraocular muscles are involved, nowadays treated with conservative management with anti-helminthic and steroid. And you have given both steroid, anti-helminthic, albendazole, as well as the surgical manipulation. Is this both attack, the surgical and conservative management, is more effective than treating with the surgical method?
Yes, sir. Actually, he needed both because he had cysticercosis in multiple areas, like in brain also, extraocular in muscles also, and intraocular also. So intraocular cysticercosis was could be removed surgically, but could not be other parts could not be treated by surgically. So for that, for other lesions, we had to manage conservatively, but because there was significant vitritis and the cyst itself was large enough, so we had to remove it also. So we went all methods simultaneously.
Okay, convinced, double hit. The reason is proven. And regarding the patch graft, there is a fantastic talk by my colleague, Dr. Rachana. And we, as oculoplastic surgeon, I think maybe the Dr. Basant here, my colleague, will also agree with me that we also removed limbal dermoid without patch graft. You know that we are not very experienced for the corneal grafting. We take out the limbal dermoid without patch graft, but there will be remaining of the stromal leukomatous lesion. The scar will be there, but the lesion can be removed in toto, and the defect we can cover with the conjunctival autologous mobilization. You know that still okay. The advantage of the patch graft is your cornea will be more clearer than living without patch graft. Is it right? Yeah.
Actually, we perform corneal patch graft in the conditions where the limbal dermoid, sometimes limbal dermoid solely on conjunctiva and the ribs area, where you can go for the superficial excision. But in the cases of limbal dermoid, which is more involved in the cornea itself, when we are debriding or debridement of the limbal dermoid, we think that the cornea becomes very thin, which is again very risky. So in that condition, we prefer a corneal patch graft, which is better for the stability of the growth. We go for the corneal patch graft.
About the classification, is the transparency better after doing a graft, or is it just for sport?
Yeah. So I would like to, before talking about the liver dermoid, I would like to counsel the patient, because the counseling part is very important. People going for the surgery. So because this is more with the cosmetic reasons. Most of the people in my OPD, patient is of teenager age. In our developing countries, more of the female patients. So they came with the cosmetic problems with this bulge out in the cornea. So there, I think the counseling part is very important. We have to counsel about the conditions itself and the surgery complication and everything, and the patient also. We know that because the patient, most of the time, patient presented with 6'9", 6'12", 6'24" at most. And we have to say that the patient that we have to counsel that after the surgery, your vision is going to be down from 1 to 2 lines, which because we are doing this much of surgery and the cornea is also stretched out because of all the sutures that we are keeping it. So your vision is going to be down, but to eliminate or to get rid of your disease conditions, we have to do the corneal patch graft. As the clarity of the this corneal patch graft, it is not so clear as before, but most of the patients are quite happy because of the excision of the graft area, and there's a little haze where the sutures are put.
And when do you remove the sutures?
So actually, we are corneal patch graft. We remove the sutures. We keep the sutures for most of the time. But sometimes the patient presented with loose sutures. So if the loose sutures we will not keep it. We have to take the sutures. So then we plan for like almost after the 6-8 months. 6 months, and then the sutures over the limbus area we cover it with the conjunctiva. We pull the conjunctiva and put the suture. So most of we renewed the epithelium and then we put the conjunctiva and put the suture in the limbus area.
On the 6 to 8 months, you put them on steroids. Will they be on steroids?
Yeah, they are on steroids, but this is a patch graft, so usually is not using that. So we don't need so much of steroids.
Yeah, we in your all cases, visual outcome was fantastic, very good, relatively, but still we expect there is a small amount of astigmatism due to the grafting things. What is your experience, Dr. Basanta? How frequently you do the limbo dermoid? It must be cases come to you frequently. Many cases, but I've never done grafting and patch grafts. Yeah. So it's simple. And only two things we have to remind the patients of. One is the diminution of vision and the opacification that you cannot get rid of. Right. So most of these patients are young, and a lot of them are female patients. And sometimes they're hesitant regarding surgery once you mention these things, but then you have to tell them, these are things you have to, after surgery, you have to bear, because otherwise there's no way you can get an absolutely clear cornea for a limbal dermoid excision, even with a patch graft. Yes, but it's been a long time now. I've done limbal dermoid young patients. But initially, yeah. But there's always that problem with opacification. So that has to be explained very well.
One more.
Yes, please.
So in patch graft, again, as you said, there's contrast, but as long as I've experienced in 10 to 11 years, but I've seen that cases where we have not done a complete or like deeper excision, there might be a recurrence chance. So there will always be a recurrence in the dermoid. But after the deep excision, even the corneal patch graft, I think the recurrence rate is quite low, as I have not studied so far, but as I've seen in literature also, the recurrence is also low.
Yeah.
Would you prefer to do it early or later? I mean, depends. I mean, if a child comes to you or young person,
So
is it better to do this?
So it depends on the location of the pneumonia. So I think of the vision. Everybody is so concerned with the vision. So if you think of the vision, if it's not sparing, it is sparing the our pupillary pathway or the vision area. I don't think we should worry about doing the surgery if it's like more and there's always a chance of myopia, so we might have to take it out. If it's not in the vision, to go under a GA is not a good thing. And also, the lot of sutures and sutures get used. Again, you go the child for to suture out for the GA. So maybe we can save some.
I mean, in terms of osmosis, is it better to do it earlier or later?
Osmosis, yeah, because it's a
It's gonna grow.
yes, it's a pneumodermal is big. Again, it's a different, and we have to go to the more regular area. Osmosis area maybe smaller size is better, but also depends on our situation. Unfortunately, the patient is able to come to the center or not. What is the follow-up? We should think of all this. Maybe this is the clinical job.
Yeah. Last question we'll take from the doctor. Young doctor, please introduce yourself.
I'm Dr. Sneha Shah and I practice ocular plastics in Mumbai. I just want to know the panel's opinion on any role of using a diamond burr to get to the base of these.
Diamond burr we use in the pterygium, mostly when the encroaching the stroma. It is very easy to use. But in the limbal dermoid, I have no experience. Maybe the cornea people sometimes use.
I was just wondering, would it give us something more like you can have not used the diamond burr, but would there be any extra benefit of using it?
For the maybe epithelial debris from the stroma, I mean, it will be much more clearer to clean up the debris from the underlying surface is much more beneficial if you have that facility, privilege to use, because diamond burr is not everywhere available. And with this, probably we'll conclude the session. And before we go out from here, all the faculties are requested to come up in the dais for the photographs. And then next session.